It looks like we've gone ahead and kind of hit a quorum, so let's go ahead and get started. So my name is Norina Allen. I'm the director for the Center for Epidemiology and Population Health within IPHAM, and I'm very excited to present today our two presenters, Dr. Sadiya Khan and John Wilkins, who are going to be talking today about the epidemiology of COVID-19 prevalence and disparities across Chicago. Just a couple housekeeping notes before we go ahead and get started. If you can keep yourself on mute when you're during the presentations, that would be great. If you can put questions you may have at the end of each presentation into the chat box, only the moderators will be able to see that chat box, but I will then pose those questions back to our speakers. We have two speakers, as I mentioned, Dr. Khan and Dr. Wilkins. Each will be presenting for about 20 minutes and then take questions. So we will take questions after each of their presentations. If you have any questions along the way, please feel free to put them in the chat box and I'll try and address them even if they're administrative or technical questions. And otherwise, let me go ahead and get started. So our first speaker today is Dr. Sadiya Khan. She is an assistant professor of cardiology and preventive medicine, and she's going to be talking today about COVID-19 susceptibility and disparities across Chicago. And I'm going to let her start sharing her screen here.
Fantastic, and thank you so much, Dr. Allen, for the invitation, and to everybody for taking the time to be with us today for the seminar. Let's see if I can see my slides okay there? Okay. All right. So as Dr. Allen mentioned, I'm going to give kind of a brief overview thinking about the epidemiology and collateral damage of COVID-19 over the next 20 minutes, thinking about the direct and indirect health effects. Our outline will be covering spatio-temporal trends overall in the United States, then zeroing in on the local burden in Illinois and specifically Chicago, thinking about excess deaths and collateral damage that may indirectly be attributed to COVID-19 and what population level health implications of this are. As you've probably all been reading in the news media, and investigative journalism has taken off in the COVID-19 era, and we're seeing a whole bunch of statistics, both in the lay press as well as in news articles and in scientific journals, and it deals with a wide variety of metrics. And I wanted to go through kind of some of the standard metrics that have been reported and talk a little bit about the pros and cons of each as we talk through the burden. So the first and most obvious one, of course, is total deaths, and really thinking about deaths per capita to normalize to a population, as well as mortality doubling time, that slope or how rapidly COVID-19 is transmitting. Total cases and cases per capita are positive test results, the total number of tests being done and tests per capita, and the elusive case fatality rate, which has been the source of much debate and even controversy. And I've asterisked these latter three because more than the first, they are highly dependent on adequate testing and case ascertainment. And as we've known since the beginning of the pandemic, that has been a constant issue related to available resources and supplies. And so as we talk through these things, I think it'll be helpful to keep that in mind. So if we rewind back about 3 months, and could we ever imagine 3 months ago we'd be where we are now, and take a look at what the distribution in the United States was in March 26th, then we see that what we recall, those early cases in New York, Washington, and the Bay Area, and if we forward a month later, the increasing density or the darkening red showing higher burden of cases really starting to move inward from the coasts and into the south, and continuing that spread. And now in the last few weeks, as we've seen surges and spikes in Texas and Arizona, we see this pattern continuing to trend with the shift from the urban coastal areas into rural southern and Midwestern states. As of July 8th, there were over 132,000 COVID-19 related deaths. And if we think about where those deaths were occurring, especially in the early patterns and how that's informing the current patterns, taking a look here is plotted in real time with the date on x-axis and deaths per capita on the y-axis across US census regions in colors. And you can see the very rapid early takeoff of the Northeast that is highly due to the heavily affected epicenter in New York and the contiguous spread in New Jersey. But I think what's also concerning to see here is how the Midwest and South have had a similar pattern in parallel and higher than the West that may be related to underlying social determinants of health that we'll talk about as we zero in Illinois and Cook County. One thing that's really important, and I alluded to earlier when I mentioned the different metrics, is that the number of cases that we're seeing are highly correlated with the number of tests performed per capita. Many people have been talking about this in the press as well because of President Trump's statements. But when we take a look and we see and we plot the tests per capita on the x-axis and the cases per capita on the y-axis at the state level, which is where this data is available, we can see there's a strong correlation between the number of tests being done and the number of cases being done. And the color coding shows those same US Census regions, with the Northeast being in the far right corner, upper right corner here, showing the highest burden of disease. And so we know that the states with greatest burden have performed more tests. That makes sense intuitively. But I think the reverse is also of concern here, that total cases and cases per capita are likely to be biased by underreporting if we're not doing adequate tests, and that's been an ongoing problem. So how can we better address this question? And one way to really look at it is think about asymptomatic testing or universal screening approaches. And some of the best data for this comes early on from the obstetrics department, where they were very forward thinking and trying to start testing all women coming into labor and delivery. So this data was published earlier this year in the New England Journal of Medicine from New York Presbyterian and Columbia's labor and delivery wards, where between March 22nd and April 4th, they tested all consecutive women coming in, so about 215. And in the high prevalence area at the beginning of the peak of the pandemic in New York, they found that 15% of women were positive. And of those, only 2% were symptomatic. So I think that tells you already that there may have been people that were pre-symptomatic and not yet having symptoms, but there's a high burden of disease among women who were not having symptoms and are relatively young and healthy. If we compare with some of our data here, we took a look between early April and middle of May. Similar approach at Northwestern Medicine across the healthcare system, and about over 2,000 women were tested. And what we saw was about a 2% positive rate. And I think Dr. Wilkins will better allude to some of our understanding of prevalence as time has gone on in higher risk populations, but in a low risk young population, this isn't surprising. One thing that we were also able to do that is maybe not surprising but concerning is the disparity, where almost 8% of women coming in for labor who were Black were positive, compared with 1% who were white. We don't have clear data on symptoms based on this data, but it does start to tell an assessment of what the burden was during April here. One of the critical things in all of this has been that flawed data really leads to flawed interpretations, and we're stuck if we don't really know what accurate data are. And this was a headline that CNN had posted about a month ago, or a couple months ago now, that showed that the CDC in 11 states were acknowledging mixing results of viral and antibody testing once antibody testing became available. And so if the government organizations and the departments of public health that are collecting this data for us are not clear on what's being collected and is accurate, then we're going to run into even more problems. And thinking about tracking trends in testing, cases, deaths, and modeling what we would predict to occur is going to be hampered even more by limited testing and accurate reporting and challenges in the attribution of causes of death. And it really leads then into the really crux of the matter. And the question is, what is the difference between the case fatality rate and the true infection fatality rate as the two metrics that we really care about? Or if you are to get COVID-19, what are the odds that you will die from it? And that seems to be something that still remains unknown, especially if we think that we're still missing 10 to 25-fold higher number of cases than we are diagnosing. And if we just look through what these equations really are doing, and you can imagine based on the case fatality rate equation, where you're counting the number of deaths that you've identified divided by the number of diagnosed cases, and the difference in the denominator between these two equations tells you what the problem is. And so in a population of young adults, the case fatality rate may be very different than a nursing home population, where it may be as high as 30%. And so you can see every time we've tried to estimate it, it's been highly dependent on the sample, and therefore is a biased result, and leads to the variability where some people have estimated as low as 0.2%, and some people are estimating higher than 10%. And part of the challenge in getting at the true infection fatality rate, which is what we ultimately care about in identifying what this denominator is having sufficient testing to be able to identify not only symptomatic, but also asymptomatic cases. If we switch gears a little bit and zero in on Illinois during that same early period and take a look at the maps that correspond to the same dates that we looked at for the United States, what we see is that really the cases started here in Chicago and Cook County with increasing burden in the Cook County area and spreading west and south. And to date, about over 7,000 deaths have occurred in Illinois, which puts us at 5 or 6 for in the country as it states. What we see when we talk about these national trends, state level trends, even county level trends, is that we're missing some of the more granularity or specificity about heterogeneity that we know is happening across neighborhoods. And shown in this map is data from the Chicago Public Health Coroner's Office, identifying the rates per capita of coronavirus deaths at the census-tract level. And so you can see the darker dense area, the darker blue areas are those areas where there's a higher burden of deaths related to COVID-19 in Chicago. And not surprisingly, these are showing up in kind of the northern area, the west and southern Chicago. What's important to know is that of all of the cases in Illinois, Cook County makes up 64% of the deaths. And if we take a look at the race distribution, over 40% of deaths are occurring in Black decedents, over 30% in Latinx, compared with 28% in white. And so even more than the disproportionate burden that's occurring in racial and ethnic minorities is the fact that they are even younger at the time of death. And so the mean age of Latinx decedents is 68, and the Black decedents is 72, compared with whites at 75, leading to a greater loss of years of potential life. And if we take a look at these geospatial clusters with some mapping, what we can identify are hotspot areas, or those areas in red shown on the map here that we're starting to show up that correspond to those dark blue areas that are considered hotspots or higher than expected death rates, as well as the contrast or blue spots or cold spots that have lower than expected death rates. And not surprisingly, these are where we would expect in terms of the hotspots being in the northwest and southern Chicago, compared with that cold spot in central downtown Chicago. What these geospatial clusters give us an opportunity to do as well is quantify what the years of potential life loss contrast is between a hotspot area compared with a cold spot area. And what we see is that the disparity where we're seeing a twofold greater burden in racial or ethnic minorities is in fact as high as 5 or 6-fold different when we estimate this metric of years of potential life loss in a high density area like the hotspot here, with a total years of potential life lost estimated due to COVID of over 2,000 years, compared with less than 400 in a cold spot. When we take a look at the census-tract profiles, so this is the distribution of these demographic, socioeconomic, and health characteristics of the neighborhoods that are classified as hot spots or cold spots, what you can see is not surprising. A greater proportion of older adults, greater proportion of non-Hispanic Black and Hispanic residents, greater degree of poverty, unemployment, and greater proportion of individuals who have less than high school education. In terms of health characteristics, characteristics that we know are associated with worse outcomes with COVID-19 are also apparent in terms of hypertension burden, coronary heart disease, and COPD. And I think this really gets at the underlying question and the fundamental causes of these disparities, in that we can see that this geographic patterning that we've identified not only reveals wide disparities, but is also very similar to that we see for non-communicable diseases. And so if you look at a map of age-adjusted prevalence of obesity in the Chicago area, we see a very similar pattern as we do for coronary heart disease. And both of these line up very, very similarly with the social vulnerability index, or a metric that the CDC has created to try to identify the burden or vulnerability in a community. And so the scale here is shown from 0 to 1, where 1 is the darkest red area. And so these are the areas that where we're seeing the greatest burden of COVID that are also lighting up as the most red or vulnerable neighborhoods. This is not unique to Chicago. There have been multiple publications, JAMA, New England Journal of Medicine and Health Affairs, that have shown. And shown here are the rate of hospitalizations across the boroughs of New York City. A here, and then the deaths per capita in the panel B here. And they've included not only the confirmed cases, but also the probable COVID have been consistently observed by neighborhood, by race, ethnicity, by income. Yeah, 2 to 3-fold higher. But one of the key points still remains, we really don't have the best sense of these disparities. Were just a few days ago to sue the really highlights here are with the coloring in of Black. Still a high rate of able to obtain data from over 1,000 counties. Only 600,000 approximately had race ethnicity data. Able to see what the distribution every age group that Black and times higher burden of having COVID-19. In addition to these racial and socioeconomic and neighborhood disparities, those individuals in state and federal prisons and homeless shelters. This report that just came out this past week shows that in the US prison population, COVID-19 escalated more rapidly, and clearly this is multifactorial, includes this close confinement, making social distancing nearly impossible, limited resources in terms of protective equipment, and higher comorbidity burden, in addition to lack of testing that is really needed to focus on outbreak control. Where even in April, the prevalence of positive viral testing for COVID-19 was over 30%. And all of these data in aggregate really make us think about the upstream to overall health. And this is from a recent presentation at the American Heart Association, breaking down the contribution of all of these factors in terms of what contributes to overall health, life expectancy, and quality of life. And if we really zero in on what the fundamental cause upstream of components that may be contributing to disparities or health inequities and all of this, and thinking about how structural and systemic racism is playing a role not only in this communicable disease that is bringing this to the surface, but in many non-communicable diseases as well. But what makes COVID unique and the disproportionate impact of COVID-19, not only in our communities, but across the United States, is this added burden now of food insecurity. Domestic violence has gone up with sheltering in place, housing instability, or the opposite, housing overcrowding and making social distancing not feasible. Unemployment compared with the other extreme of exposure as an essential worker in minority populations, reliance on public transit or not having access to testing and care, and you can see how it can all add up to a disproportionate burden. Shifting gears a little bit in thinking about other causes of excess deaths related to COVID-19 that have been observed in the same time period, in addition to those that we know are attributed to COVID-19. And this estimates of excess deaths seem to be directly and indirectly related to COVID-19, Shown here is a manuscript that came out in JAMA Internal Medicine that actually plotted the expected deaths per week from all causes of death using an average of the last 4 years in the dashed line here, and then plotted in the solid line the observed number of deaths. And what you see is the difference is excess deaths. And so they shaded in blue the ones that we know are attributed to COVID-19, in orange pneumonia and influenza, which early on may have been misattributed from COVID-19. But the tan color line shading tells you that there's excess deaths that are still left over, and it's estimated to be about 30% over this entire time period. And there are multiple causes that it could be, but the two primary ones that are of concern are under testing and under ascertainment, as we've talked about, that there have been multiple concerns that we're not testing enough, but also collateral damage related to delayed care has come to the surface. And we've seen this in multiple reports now, that number of people presenting with MI and disease is the leading cause. And shown here are data from a group at Kaiser Permanente, Northern California, that plotted over time in red the 2020 curve for patients presenting to the hospital with acute MI, and in yellow here, a year prior, the same rate. And they found that there was a 50% reduction over the same time frame. In blue are the patients presenting with COVID-19 coming into the hospital, and very similar results shown from a national data system looking at patients presenting with stroke, and saw a 40% reduction over the same time period. When we looked at our own local data in the Northwestern medicine system, we plotted the average number of presentations to the ED that were occurring, and looked in red and compared that with the number that were coming in for COVID, as you start to see the uptick here. And after the emergency was declared, we saw a very similar rapid decline in the number of people coming into the emergency department. And because, of course, I'm most interested in cardiovascular causes personally, and concerned related to delayed care, we looked at subtypes of cardiovascular disease. And what we saw in orange in heart failure, in purple in stroke, and in blue for acute MI is that there were declines in all of these conditions, but the most dramatic decline was actually related to heart failure. So if we just put all of this together and take a step and think about the impact of COVID-19 and other leading causes of death, and we'll take the month of April for an example. We know that cardiovascular disease is the leading cause of death and accounts for over 70,000 deaths per month. Cancer is a close second at about 50,000, and in the spring, chronic lower respiratory disease and influenza and pneumonia take up a large amount of deaths as well, and this was based on an average estimate from 2018. COVID-19 for this year in April was about 60,000, and so at a time when the pandemic was emerging, we see that it was really coming close to being the same number of deaths as due to all cardiovascular disease. So if we summarize some of the direct and indirect health-related effects, we've learned a lot about the direct health effects in terms of lung disease and complications of acute respiratory distress syndrome, cardiovascular disease and venous thromboembolism, as well as mental health and depression, but also the indirect health system-related effects that have affected our communities: capacity and resource allocation, fear of presenting and leading to missed events, and decrease in hospital revenue, which is also critical as we think about this transition from short-term burden of this virus to the long-term burden, not only for long-term health conditions related to lung disease, heart disease, mental health, but also in terms of the health system and what reopening in future ways may look like, the sequelae of delayed care that may be coming in, and reduction in hospital resources and closure. And so I just wanted to end with two comments that I think I've heard have really resonated with me, and I'll just take a second to read these. Dr. Gates, who's a critical care and pulmonologist, wrote, "We cannot walk out of this the same as we walked into it. We must be willing to admit that this current system is failing the most vulnerable, that we as a collective group here have much more work to do individually and professionally to decrease the health disparities gap." And I think Dr. Yancey summed it up very nicely in his JAMA piece of just a few months ago. What is the action plan? It is less an action plan and more of a commitment. Will the nation finally hear this familiar refrain, think differently, and has been done in response to other major diseases declare that as a civil society, we will no longer accept disproportionate suffering. It only takes will, and it is time to end the refrain. And it really tells us that not only do we need to act, but we'll have to act on multiple levels: national policies, equitable access to care, community level dissemination and implementation, ensuring food and housing security as well. And I think all of these have to take into account the root causes of structural and systemic racism and how those are contributing to overall health in addition to COVID-19 burden. So I'll stop. I have a lot of people to thank and acknowledge, including mentors, collaborators, all members of my research group, and be happy to take questions now or at the end.
Great. Thank you very much, Sadiya. That was a really exciting presentation and opened my eyes a lot because I haven't even seen all of that data. And I appreciate everyone kind of bearing with us as we have a couple technical issues. We have a couple minutes for questions regarding Sadiya's presentation, and if you can just enter them to the Q&A in the chat, I will go ahead and read them to Sadiya and see if we can get some answers. So the first question, Sadiya, is a high vulnerability in persons with hypertension due to hypertension per se, or possibly medications that are used to treat it, like ACE inhibitors?
Yeah, I think that's a great question, and one that we've been thinking a lot about and have been looking at a lot of retrospective data that may be biased in terms of the causal inference. And I think ultimately the risk related to hypertension seems to be one of overall cardiometabolic risk. And so I think the underlying risk factor is really driving the risk of infection severity. In terms of ACE inhibitors and other medications, specifically with ACE inhibitors, because of how the virus gains entry to the cell, the thought, or there was concern that ACE inhibitors may predispose someone to getting the infection or severity. And we do not have any data that has borne that out, and our overall recommendations as individual physicians and as societies have definitely reinforced that we are not recommending anybody stop their medication or change medication based on very limited data outside of this hypothetical concern that ACE inhibitors may increase disease.
Thanks. Another question was about, are there areas that have high social disparities but have less COVID symptoms or burden? So somebody noted that it looked like there are maybe some areas in the southwest areas of Chicago that are doing better than you might expect. Any ideas?
Yeah, I think that's a really important question, and one that we noticed as well when we looked at what the social vulnerability of an area was, in some areas that had lower than expected burden based on that high social vulnerability. And I think it's one that I don't have a great answer for, but is, I think, maybe an area to better investigate and study, to think about what are the assets in a community that may be protecting them from having as high a burden.
And I'm going to take just one last one, but what about gender disparities? We've been talking a lot about racial and ethnic, but there's obvious differences by gender.
Yeah, I think we have seen some disparities that I have that are still not clear is related to the age distribution of the deaths. And since we don't have a lot of national data on what the age distribution of individuals are that are dying, that I think there's a potential that there may also be that some men are older when they're getting it, but I don't think it's clear on the absolute count or the crude counts. It seems like men are dying at a higher rate.
Great. Well, I know there's lots more questions, but in the interest of time, we're going to go ahead and move on. Please feel free to contact Sadiya directly or myself, and happy to kind of start a conversation about some of the additional questions. So it's my pleasure to introduce our second speaker today, Dr. John Wilkins. He's an associate professor of preventive medicine and cardiology. As a quick plug, he's also the leader of the Center for Epidemiology and Population Health's research core on pooling data. So he's going to be talking today about his work in the Northwestern Medicine Healthcare Workers SARS-CoV-2 serology study. And I know he's going to emphasize this, but these are preliminary results, so we get the inside scoop about what's happening as it's going.
Thank you, Nori. Can everybody hear me? Good. Okay, great. First off, thank you for the invitation. I really appreciate an opportunity to share some of our very preliminary results, and also want to compliment Sadiya. As always, Sadiya, really a fantastic talk, and actually gives a nice context, I think, to interpret, some of our data. So without further ado, get started here. So it's just an introduction, as you are all well aware, and as Sadiya mentioned as well, there's a lot of fundamental questions about SARS-CoV-2 serology that are currently really not understood. Basic questions about prevalence rates in communities, in particular rates in healthcare workers, which our study seeks to illuminate. The limited data we have thus far, there was a relatively large Spanish community study or surveillance study that showed about estimated a 5% seroprevalence rate of IgG serology, IgG and IgM actually in Spain, that was higher in urban areas and slightly lower towards the coast. They looked at a subgroup of their sample, and they reported about a 10% prevalence rate of IgG or IgM seropositivity in healthcare workers. They didn't really define them very specifically. And then there was a Belgian convenience sample that reported about a 5% prevalence of IgG seropositivity in Belgian healthcare workers that identified really home exposure, meaning someone else in your house who had COVID-19 as being probably the strongest predictor, and really modest effects of work-related exposure in that very small study. In fact, it was published as a research letter. We also have major questions about the incidence of serologic conversion, and I mean going from negative to positive, but also actually going from positive to negative status and the duration for which someone is positive. And we have very little data actually about the risks for incident COVID-19 disease or infection by your serologic status at baseline. Clearly, healthcare workers working in endemic areas are exposed to SARS-CoV-2 differentially across different occupation groups, meaning your job certainly has something to do with how much SARS-CoV-2 you encounter. This makes, from a research standpoint, them an ideal group to study. There is adequate, quote, risk for people to have events. So we have power to detect differences perhaps across occupational groups. And certainly, I mean, it's clear that understanding the risks for infection are certainly very important to healthcare workers. As a healthcare worker myself, I can attest to that, certainly. There's a need to understand these risks for infection, as probably everybody on this call is well aware. It's not looking promising that SARS-CoV-2 or COVID is going to go away anytime soon, and we may be dealing with upcoming waves of this virus in the future. So understanding risks for infection and how to lower those risks as much as possible is really vitally important to handling upcoming waves of this disease, of this illness. Excuse me. There we go. So, when we started our shutdown in late March 2020, I was having conversations with colleagues, in particular, Mark Huffman and I were talking and trying to figure out what is something we could do as people trained in epidemiology that would be really most useful. Apart from signing up for the labor pool, we thought we should probably create a cohort study of healthcare workers to try to understand some of these basic epidemiological questions and clinical questions basically around COVID. So I assembled a multidisciplinary team. All team members are shown here. You can see that the physicians are across different specialties. Myself and Mark are cardiologists, Teresa Zembauer in infectious disease, Amisha in endocrinology, Lisa Hirschhorn in infectious disease as well. We had epidemiologist, Charles Nika is my co-lead investigator on this study, help from our bioinformatics colleagues. And then I got to give a shout out to the All of Us research program. They weren't conducting a lot of their research early on because of COVID-19, but they were willing to come over and help us, and their infrastructure was just crucial. And so Naomi and Ajoma and Joyce have just done absolutely fantastic and pivotal to this. And then our biostatistician, Lib Gray, has just been incredible, as have our partners from NM, who have really helped us execute the aims of this project. And this is not an all-inclusive list, so there are many more to thank. But anyway, I just want to get into the data for you. But NM also provided a benefit to NM employees, which is to get free IgG serology testing that started in May 30th. They allowed us actually to embed our research program actually in this benefit to NM employees, which really allowed us to construct this cohort actually rapidly, and we'll go through all that. But we thought this was just too perfect of an opportunity to miss. Certainly we have a high prevalence and incidence of COVID-19 in this area. And I also thought that Northwestern medicine was actually a really great health system to study because, as Sadiya showed, the migration pattern of the infection started at the coasts and worked its way to Chicago a little bit later. We had time to prepare, and thankfully we had the resources to prepare. So we had a health system that actually was able to generate, effective infection control policies, supply PPE to its staff. And so I think we're a pretty good model system to estimate what might happen in the future if we get more waves of COVID-19 and prepared health systems encounter them. So the objectives of our study, essentially, first, the overall objective is to understand the prevalence incidence of SARS-CoV-2 serostatus and the risk for incident COVID-19 in NM healthcare workers. Our specific aims for the study, our first one, which is what we're really going to focus on today, was to quantify the prevalence of SARS-CoV-2 serology in NM healthcare workers overall, and then stratify that sample by age, sex, race, and occupation group, specific occupational tasks, and symptom status over the preceding 4 months. We're also, as a sub-aim, but we haven't gotten there yet, are going to compare prevalence across different SARS-CoV-2 serologic assays. Aim 2 is to quantify incidence of serostatus conversion, and aim 3 is to explore risk for incident COVID-19. Aims 2 and 3 will obviously require follow-up, and today what I'm going to do is present some of the preliminary data we have for aim 1, our basic prevalence aim. This is our basic cohort study design. So from really May 26th through actually today, we have been recruiting participants to participate in the cohort study. Participation involves having serology drawn via venipuncture, administration of a baseline survey that asks questions about basic demographics, past medical history, and occupational history. We offer serum banking to a subset. Those individuals are then going to be followed over time, administered monthly surveys to assess the development of COVID-19. And then we plan to do a repeat blood draw in the fall of 2020. And then we'll continue to follow until June of 2021, again, for incident COVID-19. Certainly the baseline data allows us to look at, to answer the questions posed in aim 1, which is what I'm going to present preliminary data for you today. And then with the sort of longitudinal nature of this cohort study, we'll be able to look at our incident aims, including incident serologic conversion and incident COVID-19. Our methods kind of outlined briefly here. Again, we took a convenience sample. Most participants were contacted via email. NM sent out an invitation for free serologic testing. Embedded in that email was an invitation to participate in our research study. We did partake in some targeted recruitment of environmental services, food service, and patient transport workers, as we realized that many members in those groups really don't check email very frequently, and so we were certainly undersampling those very important occupation groups. If someone consented to enrollment, they were administered an electronic survey via REDCap, again, that asked about demographics, past medical history, occupational exposures, COVID history, and COVID symptoms, and they will be receiving monthly surveys asking for essentially symptoms related to COVID or a COVID-19 diagnosis over the ensuing follow-up period. Serology, as I said, was obtained at or around the time of the survey. Serology was measured via the Abbott Architect nucleocapsid IgG assay. That is one of the currently commercially available assays. It has a reported sensitivity and specificity of greater than 99%. There's some literature out there on that, but there is no assay for COVID diagnostics that I would say has been rigorously evaluated, and more work definitely needs to be done in that space, and I will share some data to illuminate that. And then we were able to link REDCap survey data to their serology results and any COVID-19 testing that occurred, PCR testing, et cetera, via the EDW. Again, we did serum banking. Right now, we have serum stored in about 1,850 participants that is actually stored in pathology for future assay validation work. Where are we right now? Well, since May 30th, 2020, we've actually approximately 19,000 NM healthcare workers. That's 19,000 out of about 38,000 NM employees have had their serology checked, and of those, 6,347 are currently enrolled in our cohort study. Enrollment is actually still ongoing via email invitation to some individuals. Okay, so I get to go through that quickly, but now I wanted to sort of touch on our preliminary results. And again, literally, these results are about 36 hours old, okay? So what I'm gonna be presenting here are very crude, basically prevalence rates. None of these numbers have been adjusted, but I did want to get it out there for the research community and that people start thinking about it. But I also want to make sure we get these information out to the NM community in a fairly quickly. Okay. So this slide here, this is from our EDW dashboard, okay? And what this is showing you at the bottom is the sort of the percent of our total sample that is represented by the occupation groups shown here on the x-axis. The different colors represent the serology status that we have for each group. So gray means we don't have a serologic result. Orange means that this person is negative, or that this, orange is percentage that is negative. Blue is percentage that is positive, okay? The take-home messages that I want you to get away from this particular graphic are that the majority of our cohort were registered nurses or equivalent, followed by physicians, followed by individuals who are identified to be in an administrative role, and then the category of other was any group that had less than 20 individuals in it, just for the purposes of maintaining participant anonymity. They are being lumped together. And then you have nurse practitioners, physical therapists, et cetera, and you can see the other kind of list of occupation groups. We clearly got a very broad sample, and we definitely have a heavy sample of people who would have a lot of face-to-face patient contact. So there's definitely a spectrum of risk, if you will, or a spectrum of exposure in our sample. And we have very sort of large numbers across really the major occupational groups that are encountered in clinical care. All right, now I'll go through the seroprevalence rates in a minute, so we'll touch on that. This is our table one, kind of basic demographic characteristics of the sample of the sort of major, some of our major occupational groups. I'm going to draw your attention to the overall column, which is shown here. We're really going to spend most of our time on that. You can see the end here is 5,604. Now remember, I mentioned to you that we had over 6,000 in the cohort, and we do, but we're still in the process of creating the linkage between REDCap and EDW. That's not an instantaneous linkage. So that's why this number is a little bit lower than the number I shared with you before. But the median age of our sample is about 40 years old, so it's a relatively young sample. The vast majority are women. It's actually 79.9% of our respondents were women. I'll say I initially thought that, you know, this was I mean, it clearly isn't oversampling to some extent, but this was perhaps due to the fact that women are more likely to participate in observational research such as this. And there is some evidence that's true, but actually when you look at the demographics of the sampling frame, it turns out the majority of healthcare workers at NM, in fact, are women, and it's actually close to 78%. So I think that's actually in of itself an important thing to emphasize. The front line in caring for COVID is mostly women. Our demographic breakdown by race, ethnicity, ethnic group is shown here. We clearly had a really significant undersampling of non-Hispanic Black participants. Again, the ethnic breakdown, or the percent of NMH, at least, employees who I self-identify as Black is really closer to around 11%. So we definitely undersampled there. Hispanics is somewhere around 10%, and we got 7.3% of self-identified Hispanic individuals in our cohort, and then 76% white. We had 2.8% diabetics, and 12% of people stated that they had hypertension at cohort enrollment. Forgive me, I'm not going to present these numbers for the smaller occupation groups simply because the numbers kind of get too small, and I think there's potentially risk of losing participant anonymity if we do that. But you can see here the overall N of the different groups. We had 763 administrators, 113 medical assistants, and 1,084 physicians, and about 1,500 nurses in the study. Okay, this is a complex slide. This is going to take a little bit of time to go through this, but I think this is really vitally important, particularly given some of the points that Sadiya brought up around there's questions as far as the performance of any of these assays. Okay, so at the top, I'm going to point out, to say it, our IgG crude seropositivity rate was 4.8% with a confidence interval of 4.3 to 5.4. This is among our entire sample. This is not adjusted. This is not weighted. This is just a crude percentage, okay? But what I'm showing here is I told you that we have a linkage to the EDW, okay? So of our entire sample of 6,000 some people who had serology checked, 980 of them also had PCR checked, okay? And so what I was interested in is looking at the concordance or discordance, okay, between PCR results and serologic results. Now, you can't do that and ignore the temporal relationship between those two variables. So I didn't want to just show you guys a 2x2 table because it's frankly not interpretable. Okay, so this is, just bear with me and I'll walk through this with you. So what we did is we broke those 980 individuals up into 4 mutually exclusive categories. And that's sort of a 2x2 table here, which is their IgG is positive, their IgG is negative, or their PCR test was positive, and their PCR test was negative. And just so you know, most people really only had one PCR, but if they had more than one, we would take the positive one, but it doesn't really confound this very much. On the x-axis here of each table is the date of the COVID-19 test. The COVID-19 is the PCR test that they had done. So in April, May, June, or July. And then the date of their serologic study. That's the blood draw that we did for this study here on the y-axis in April, May, June, or July. Now, some of you may be aware or may not, but the serologic studies were not available, at least at Northwestern, until really mid to late May. And our study didn't begin until really May 30th. Okay, so that's why all of the serology results you see are really occurring after June. Okay, this one person here sent their lab out to Quest, so they were offering it earlier than we were. Okay, this line that goes to the middle of the plot is really the line of unity. So if any point, which every point represents an individual, if any point were to fall on this line, that means that they got both their serology test and their PCR test on the same day. You would not expect that to occur, and actually it really didn't occur except for very few people here, okay? If someone is to the right of this line, they just got a red, they were given a red dot. What that means is they had their PCR test done after their serology test, and if they're to the left of this line, it's the opposite, okay? So now I'm gonna walk you through this, and so we're gonna look at the concordant groups first, okay? So this is a PCR positive, IgG positive group. The point here is the majority of people, okay, who are PCR positive are in this group, and that's what you would hope to see. Meaning if they had PCR evidence of infection, they also developed the antibody. All of the people, again, who were COVID-19 positive and serology positive, I'll rephrase that. We did not have anybody who was serology positive and COVID-19 positive who went on to develop COVID-19 again, okay, after the cohort. Okay, so there's no incident COVID in this group. Okay, so this is really the group that's behaving the way you would expect. Go down here, these are people who are PCR negative and IgG negative, okay? And this is just sort of a random clustering. You would not expect that there's any real temporal relationship here. If you didn't have the disease, you didn't have the disease. It doesn't really matter when we test you, and that's what we see here. This is our first discordant group. These are people who are serologically positive, so they had the antibody, but they were PCR negative, okay? This is these discordant groups are due to either assay performance, biology, or just the testing relationship here. And so what this means here is these are people who, so they had a positive antibody, and for whatever reason, their COVID-19 test was negative. That could have meant that they were tested too late, sort of after the development of their illness, such that their level of viral load in their nasopharynx, for example, wasn't high enough. It could have been a false negative of that test. Or in the situation of some of these people, it may be that they got their serology result, found out that they were IgG positive, and for whatever reason tried to get a PCR test to make sure they didn't have the disease. You wouldn't expect that they would necessarily be positive if they'd already mounted an antibody response. I think the most compelling group to look at, unfortunately it's a minority of this sample, is right here, and that's the top left here. So these are people who were PCR positive, okay, and had negative serology. Okay, and that group is a little troubling. So we have people here who back in April, okay, were PCR positive for COVID-19, who in June, after June 1st, were actually negative for serology. This suggests, I think, one of two things. Either there are assay performance issues, either they were false positive PCRs, or we're getting false negative serology results, which is certainly a possibility. No test is in fact perfect. And or the level of antibody that they have is below the detection limit of this assay, which frankly is not well characterized, but we hope to look at that. Or a more troubling implication could be that the duration of antibody positivity could be less than 1 to 2 months in some individuals. I hope that's not the case, but I suppose it's possible. And then these people here, this red cluster here, these are people who are PCR positive really after the cohort. So these represent people, sorry, PCR positive here. These represent people who have developed incident COVID in our cohort. So we already have 1, 2, 3, 4, 5 individuals who've developed COVID over the last month of follow-up, okay? I know that was a lot. Each slide will not be that complicated, but I thought that was important to go through with you, okay? Now I'm gonna show you some of our seroprevalence rates. Again, these are all very crude, stratified by different groups. Here we have them stratified by gender and different age groups. So again, looking at people who identified as female or male, again, the gray bars represent people for whom we do not have a serology result. Orange means they're negative, and blue indicates the percentage that were positive. And looking across people identify as men and women and men, we really don't see any substantial nor likely significant difference across those two groups in terms of seroprevalence at baseline. This is the sample stratified by age. Just so you know, we do not have children in our cohort, but there are some people that are 18 and 19, and their prevalence rate was 0, but that's a relatively small number of people. And then we have people stratified by decade of age, 20s, 30s, 40s, and 50s, as you can see here. It does appear that there is a slightly higher prevalence of seropositivity in people in their 20s, but then it appears to be, again, less in people in their 30s, 40s, and 50s, but it doesn't appear to be a sort of graded response across increasing age groups. These are again, our crude unadjusted seroprevalence rates by race ethnicity group here. Over in the far left here, forgive me, this is percent positive on the y-axis. Hispanic participants in our cohort had a seroprevalence rate of about 10%. Non-Hispanic blacks at 7.8%. People identified as multiracial were about close to 5%. And then non-Hispanic whites, others, and Asians were really in the 4.2 to 4.4% seroprevalence rate. These numbers are, although we don't really have, I think, great quality seroprevalence data from Chicago, you know, they are consistent with some of the trends that we've at least seen from the limited data that we have thus far on community rates. Excuse me. Here we have the unadjusted percent positivity by different occupation group. Occupation group is down here on the y-axis. This is also percent, forgive me, I don't have a label here, but this is again percent seropositive rate, again by group. Interestingly, in our sample, medical assistants actually had the highest percent positivity rate at about 10.6%. Others, again, this is any group that was less than 20 individuals or around 8.3. I can tell you that's a broad array of different job types. Respiratory therapists and nurses were around 7.5 to 7%. Respiratory patient care techs were 6.2%. And then administrators, where are they? There they are. People who identified as an administrative role, which I thought could work nicely as potentially a control group, as in they're working in the same place, but the majority of whom do not have direct face-to-face patient contact, though we are drilling down on that now. We're at 4%. And physicians were 3.4%, as you can see here. And then the other occupation groups are shown. Here, we actually did ask people about medical specialty. I really wish we could have done this for our nursing staff as well. It's just that the way that the workforce implementation was occurring in the pandemic, a lot of nurses were being sent to a lot of different units and were working in ways that they don't typically, working in units that they may not typically work. And so we really couldn't get to that level of stratification. But amongst physicians, we actually had the highest seropositivity rate in surgeons. Pathology was driven by a relatively modest number of people. So there's a pretty large, I think, confidence interval around that. But anesthesia was at 5.3%, emergency medicine at 4.8%, and then medicine was down at 3.3%. Of the medicine subspecialties, I think notably are pulmonary, all the people identified as pulmonologists and critical care doctors in our sample, pulmonary doctors, excuse me, had a prevalence of 0%, which I think is very notable. Okay, this is broken down, seroprevalence broken down by reported exposure to patients with COVID-19. Participants who said they were definitely exposed to patients with COVID-19 had the seroprevalence rate of 7.4%, and it was 2.8% in people who said they were not. People who reported COVID, quote, floor work, which could be interpreted to mean an ICU or general floor had a 7.5% seroprevalence versus 3.8 in those who did not. And then high-risk care, as identified by the participant, was at 7.3. Broken down by occupational tasks, as you can see here, frequent ICU work was associated with 5.2 versus 4.8%, so no real substantial differences there. We did not see really substantial differences for intubation, extubation, bronchoscopy, or TEE either. High flow O2 nebulizer therapy did seem to have slightly higher prevalence rates in those groups. Surgery in itself, being present for surgery, did not. Hemodialysis, if you were present for hemodialysis, individuals who reported that were at a slightly higher prevalence rates than those who did not. Labor and delivery did not appear to be substantially different. There might be a slightly higher rate in people with colonoscopy, but again, these are totally unadjusted, so we don't know yet. This is really one of our last kind of key slides here. Interestingly, when asked about out-of-hospital exposures and beliefs about personal COVID-19 infection, those appeared to be pretty strong predictors. So if someone said yes, they definitely had an out-of-hospital exposure, they had a percent positivity rate of 14.6% versus 3.4 in people who said no. Similarly, if you asked people, people who reported that they knew they had COVID-19 because they tested positive had an 82.7% positive rate. If they believed they had COVID, but were either tested negative or didn't test, it was 6.4 to 10.3. And they who didn't believe they had it were 1.4%. Anyway, so limitations of our study, I mean, it's a convenient sample and there is some underrepresentation of Black and Hispanic minority groups. We have survey data and there's all the limitations of survey data. Some individuals took their surveys after they got their serology results. There's some recall bias. And assay performance is not yet clear, and that needs to be rigorously studied, which we will be doing. Okay, so in conclusions, crude seropositive prevalence rates are 4.8%, which is close to estimated community seroprevalence rates in some endemic areas. PCR positive and serology negative patients were observed. Prevalence rates appear to be higher in younger Hispanic and Black participants. Exposure to COVID-19 patients was associated with higher prevalence of IgG positive, but individuals and teams that provided ICU care, performed intubation and bronchoscopy did not appear to have higher IgG positive prevalence rates than those who did not. Data suggests that infection control policies that are in place currently to reduce risk for SARS-CoV-2 transmission during high-risk procedures are effective. However, in non-ICU settings and out of hospitals, healthcare workers remain at substantial absolute risk for SARS-CoV-2 infection. I think the implications here are that we certainly need to develop more rapid and accurate testing for COVID surveillance to identify those at risk to transmit SARS-CoV-2. Infection control policy should include assessment of out-of-hospital and family exposures, and further investigations are needed into these PCR positive, serology negative participants. With that, I'm going to stop there. Basically, our future directions are basically to complete our data collection and data cleaning, et cetera, and then complete the aims of our study. And thank you to all of our partners in this project. I'm open for any questions. Thanks.
Great. Thank you very much, John. It's interesting to see kind of that first peek, and I know you're going to get a lot of questions you may not be able to answer yet, but before I take one or two of those, I wanted to give a shout out and say congrats to you and the whole team for putting together an impressive study in a very quick timeline. I know that's a challenge. So I'm just going to ask one or two questions, and then if you have additional questions, which I know there are some, please reach out to John or myself and we'll try and get you an answer. One question was, what do you guys plan to do to increase enrollment among non-Hispanic Black participants, especially given the higher rates we know that are affecting that community?
Yeah, we have been trying to do, we did some targeted recruitment of, we're really more focused on occupational groups that were underrepresented in the sample. Many people though, many members of those occupational groups are members of underrepresented minorities. In fact, we just had a in-person recruiting session And I'm certainly open to other, other suggestions, but we'll also be doing some targeted email recruitment, but that's all we have at this time. I guess, although there certainly is an underrepresentation, our absolute numbers are high enough where we have, I think, a reasonable amount of confidence over the estimates that we're getting of prevalence in those groups. And certainly our overall, seroprevalence rates are going to have to be weighted by the race, ethnic, age, other demographic sort of characteristics of the sampling frame.
Definitely, and I know you haven't had time to do that, so I'm sure that's the next step. Last question before we go. People have asked about, did you ask other questions about personal behavior and how they affected prevalence rates? I know you asked some things about testing within a family or family exposure, but did you ask others?
We did. I mean, what I showed is actually a pretty modest fraction of all that's on the survey. For those of you who participated in the study, I mean, you'll know you've had the cohort, you've taken the survey. We had to walk the fine line though between making a survey that people who are sort of busy healthcare workers could actually take pretty quickly, and getting data that we thought was reliable. I think asking people if you get too detailed about their behaviors, I think your confidence in the accuracy of those reports might diminish over time. So there's a point of diminishing returns. We tried to walk that line, but yeah, we did ask about other behaviors, things like, did you wear PPE all the time? Things like that, but there were pretty specific questions about occupation. We didn't ask as many questions about what you did at home, per se.
Well, I know we always have to be pragmatic. Well, I know there's other questions, so I will send them to you, John, and hopefully they can follow up with you. And I know we'll see more about the study as it continues and develops. So thank you both of our speakers, Dr. Khan and Dr. Wilkins. And I appreciate you all joining us this afternoon. And please keep in touch with the Center for Epi and Population Health as we continue to work on COVID and other public health issues. One last plug, as John mentioned, the All of Us research staff were critical in the NM healthcare workers and are also really working hard to recruit participants for their study, the All of Us research program. So you can see in the background just some information about that program, and we hope you all check it out. Thank you very much, and I hope you all have a great day. Take care.